My name is Patrick Shaughnessy. I'm one of the Band 6 physios at Southmead. This afternoon I'm just going to briefly look at spinal trauma and spinal fractures, key learning and clinical considerations for mainly therapy staff. Spinal fractures themselves, you can go really in depth with them. I'll try and give a brief little overview throughout the presentation, but I can just kind of cite people to where you can learn a lot more, because I think in depth they need quite a lot of presentations to themselves, not just everything in one. So the learning objectives from this afternoon will be, so what are spinal fractures, the causes and types of them, and we'll look at specifically C-spine fractures and the classification of those and their management plan. Then we can look at thoracolumbar fractures and similar again, the fracture management, so how we manage them conservatively and surgically here as part of the network, and the physio involved in these patients, and then a brief little discussion about whether we use braces with patients and how we manage that. So, spinal fractures, so they can obviously occur due to a variety of different reasons. As you can see on the screen, so the most common cause related to trauma, such as high impact road traffic collisions, falls or jumps from a height, or sometimes high impact sports as well in the younger population. Other causes which we won't really touch on in this, as it's not specifically trauma, is pathological fractures such as osteoporosis or cancer. And there's several types which are all based on the patterns of how the person injures themselves, whether it's an extension or hyperextension or a rotational injury, which we can briefly chat about, and also the extent of how involved the spinal cord is, or if there's any ligament disruption as well. So today we can divide this into C-spine fractures and thoracolumbar fractures, as I said. I'll touch on the different types. As a general rule of thumb though, for therapy staff, because you'll hear people say a lot about unstable fractures and stable fractures. So an unstable one would basically involve the vertebral body, ligament disruption, and involvement of the spinal cord. C-spine trauma itself is a common problem with the range of severity ranging from minor ligamentous injuries to frank osteoligamentous instability, which would be where the whole spine is disrupted. Or vascular compromise, where we could have a bleed, or spinal cord injury, which could be a complete or an incomplete injury. The C-spine itself, why we're talking about it a little differently, is its makeup is different to the thoracolumbar spine itself, and the injuries sustained there are quite different and quite life-changing. So C-spine trauma itself, just a brief little overview. The incidence rate is approximately 15 in 100,000 will have C-spine trauma. 18% of those that we'd see here roughly convert to having surgery. C-spine fractures are greater males than females. The demographics over the last 20 years really have shifted, if I'm honest. So it used to be your younger people in car accidents and in your falls from a height. Whereas in the last 20 years, I think it's really shifted towards your 65 years plus, where they've had a fall at home, which for them is still a fall from height or a slip down the stairs. The highest incidences, as we can see, are between 15 and 45 and 65 to 80. And RTAs and falls, as I said, are the most reported mechanisms. As I've said, especially during the pandemic, we've seen a large increase, unfortunately, of people sustaining these fractures and injuries from falls or jumps from a height as well. The region that's most common and the most fatally injured site is C1 and C2, followed closely by C6 and C7, which is near the junction moving into the thoracic region. And you'll notice across the rest of the spine as well with thoracolumbar ones, they usually occur at the junctions as well. So your T12 and L1 fractures are really common, and then lower down you've got your L5 and S1. So everywhere where the spine starts to move on to the next level are really common because of the movement variability. 2 to 4% of trauma patients have C-spine injuries. 20% of those roughly have a spinal cord injury. Of all spinal cord injuries, about 55% occur in the C-spine. 10% tend to be polytrauma, so we'll have another fracture or possibly more. The variance of C-spine injuries that get missed is quite high, as you can see in the stats. And as I've said, the majority of patients that do have a C-spine injury tend to have other injuries as well, whether it be head, chest. Most of them tend to also have a traumatic brain injury. And a really important one for any working in an ICU, so 5 to 10% of unconscious patients, if they've had a fall, usually have a C-spine injury as well. So the fracture patterns or the mechanism, so obviously the direction of force will really depend on what type of injury they get. So hyperflexion is the most common, hyperextension, then you've got hyperrotation, so over-rotation, axial loading, which if you imagine is top down or bottom up, so top down if something has come on top of them, or bottom up if they have fallen from height and landed on their feet and the force has gone up through the legs, up into the spine. And a distraction is a pulling apart or inside the vertebrae itself. It can be described as an internal decapitation. So how you classify the fractures is basically a couple of different theories around them. So the most commonly used for C-spine, as we can see, are the Denise 3-column fracture, which has been around for quite a while. This is the one that uses the terms stable and unstable, and then the AO spine classification as well, which I'll touch on shortly after this. So the Denise 3-column theory splits the spine into 3 different colours. So we've got blue, green and yellow or orange, which is anterior, middle and posterior. And as you can see here, it's the different sections that they're divided into. With this type of fracture, so that basically instability occurs when 2 or more of these columns are involved, so i.e. the anterior and the middle column, or it could be the middle and the posterior. So if one's usually involved on its own, it tends to be okay and they'll manage it conservatively. If you've got more than, if it's all 3, they're definitely going to be having surgery. If it's 2, it tends to be a kind of discussion between the consultant, the patient, or the consultant and therapy staff asking how they're doing. Are they able to have a standing x-ray where they can look at that spine and stand and see does it change the stability of the spine. If we move on to the next one, so how they diagnose it. So a number of different ways. Your standard x-rays, usually difficult to detect your more complex ones. CT, so it'll usually bring up your fractures for you. It might help with the extent of the fractures and maybe show you some ligament involvement and see if there's stability there or instability. Your MRIs, most consultants, if they're really worried about something, will have an MRI for the patient. You'll be able to see how much, if there is any spinal cord involvement. It's usually the most sensitive for detecting these sort of injuries. It's worth noting here, especially in Southmead, as a major trauma unit or complex spinal surgeons, for any of the ones that if they're really concerned about, they'd be going straight to theatre and they'd know there's a massive ligament injury or spinal cord injury, and you'd know that from assessing them on a bed as well. If they weren't sure and it was a fracture that you could manage conservatively or surgically, they will tend to say physios can get them up, and they'll have a standing x-ray if possible, and they'll look at them with that and give them 24 to 72 hours based off the x-ray and how they're doing with therapy. If they're doing okay and they're able to get up and move with us, then they tend to just say we'll manage them conservatively and we'll go on from there, to be honest. The AO classification, which we can briefly touch on as well. So this divides the spine into different areas and gives different scores, and I'll put a link and we can obviously send out a presentation as needed if people have other questions, but it divides them into different areas. So in the C-spine, C0 to C2 are those type of fractures, and then they grade them in like an A, B, C, D. And same thing, so type A, type B, type C fractures have a specific mechanism of the injury. And there's a free app from AO that you can download, and you can put in what they have, and it'll basically tell you how that's usually managed. So it's quite a handy one. Denise, as I said, for stable and unstable. So stable fractures tend to be the ones here on the left, while unstable tend to be these ones. As I previously mentioned, it's really difficult. We could spend a whole session just going through a stable fracture and an unstable fracture, and we'd be here quite a while, to be honest. So it warrants kind of a session on its own. But for some advanced reading, you can look up these things quite readily. And I've put a few links along the presentation on where you can do that as well for a bit more reading. But from a therapy perspective, you'll usually know from the consultant how that's been managed, or if they have come here for treatment, have come back to your own local hospital. It's quite helpful then that you'll already know the management plan in place, but you can kind of look into the fracture yourself for some more learning. The reason with these type of ones that they will tend to not use the word stable and unstable so much as a consultant anymore is, to them they'll ask you what does stable or unstable mean. So these don't technically with Denise tell you if there's a cord involvement or if there's any ligament instability there. So for a consultant, it's not the best of markers anymore, and it's in their eyes quite dated. But from an orthotics point of view, and with therapy staff as well, and some more junior clinicians, you'll hear them always use the word stable and unstable, but within consultant level, it's not really used anymore. So how we'd manage them conservatively and why they might choose to be conservatively managed tends to be they've not got any neurological deficits when they're assessed. It's purely osseous, so a bone injury, and that there's no instability at that level, that there's any variation for large movement of the spine at that level, and it would usually be just in one level, and you've not got a couple of spinous, or you've not got a couple of levels of the spine that are all unstable together. So if it's usually one level, it's 2 levels max, they'll manage it conservatively. The ligament complex at the back of the spine is preserved, so there's no damage to that. Usually if that is damaged, it would warrant surgery on its own. As I said, predominantly 1 column injury. With the AO classification, so AO is A1 to 4, which you can see on the other slides, they'll manage them all conservatively. Mild to moderate pain, so they're able to get up and function and move around with therapy staff. They've not lost more than 30 to 50% of the vertebral body height. They've not got more than a 30-degree angulation or kyphosis at that level. There's no more than 20-35% of a spinal canal compromise, and at the C-spine, usually for those, they will put them into an Aspen collar, and they will go into that for 8 to 12 weeks. Depending on how the fracture looks in a standing X-ray with them, they might say it needs to be on constantly for 8 to 12 weeks, depending on the consultant. And some might say it can come off, as an example, for when they're in bed, or it can come off when they're getting showered. During the day, we always recommend it comes off 2 or 3 times for the patient, just to let air into the area of their neck, allow it to breathe, because you can get quite a lot of pressure damage if it's just on constantly and they're not looking after the skin. So moving on, so just a quick look at the different types of things they might use to manage these fractures. So not really seen as much anymore. So the halo, so if you're like a C0, C1 level, they might put them in a halo if it's really unstable and unsteady, and they're worried about how that'll heal. But obviously, because of the degree of movement there, it can go any way, so they tend not to heal very well unless they really immobilize them. Your Aspen Vista collars do a bit more than a Miami J, so they should cover to C7 fractures really. When you're wearing a brace or a collar or anything like that, you should always have stability of the brace or the collar, a level above and a level below the fracture itself. So if this covers to C7, that means the fracture shouldn't really be any lower than C6. And if it was a C7 fracture, realistically, you're looking at putting them into something like this, which is a CTO brace, which is a cervical thoracic orthosis, and that will give them more coverage down into the thoracic level as well. The way orthotics will look at this, or if your own hospital, if it's physios that manage it, you need to think about the motion that they're going to have and what you're trying to immobilize at that level, and you can pick and choose alongside the orthotics team what best to put them in. If they're transferring back from this trust, we should already have that in place. Just with a bit of a differential diagnosis, relatively common but uncommon at the same time, so just something extra to think about for advanced clinical reasoning really. So traumatic vertebral artery injuries, it's a common finding in trauma patients, especially who have had head and neck injuries. It's a vulnerable injury to any rotational torques or torsion injuries. You can suspect it really, as it says, if the mechanism of injury is a hyperflexion or hyperextension, so that can sometimes be your whiplash injury where they've literally gone like that and back in. It's usually associated with the upper C-spine, and because of the actual route that it takes, and it comes around C1 to come up, you usually find that it can be easily damaged because of the route it takes itself, the vertebral artery. Most patients are usually asymptomatic, and the symptoms develop a couple of days later, sometimes weeks later. With that, it's a high-grade injury. If it's really high at the time and at the level of trauma that's occurred, they can sometimes be symptomatic early on, but it's just being really aware that it is a possibility. We're lucky here, I suppose, that they should be getting numerous CT scans when they arrive if they're a major trauma call, and stuff like this can be quickly ruled out. But not, I suppose it's common but uncommon at the same time, which is something to be wary of, and is a massive risk for any further damage, and long-standing damage as well, I suppose it's worth saying. As it says, so leading perfectly into that, if they did have any of those injuries that went undiagnosed, you can have brainstem or cerebellar infarcts leading to a stroke, or if it really goes unnoticed, the patient could die from it. It is under 45, it's a high incidence of stroke. There's quite a lot of research out there with stuff like this happening with rugby players. Under the age of 45, it's quite common with people in 20s and 30s, obviously playing high-level sport, neck, with the variability of movement in stuff like scrums. It can happen, so although you see people come in fitting well and they do have some neck pain and they're found to have a fracture, if you're starting to notice some strange things with the patient, it's worth keeping this in the back of your mind. The most common region is C2 to C6. High-risk injuries include fractures of the transverse foramen and upper C-spine. So yeah, worth being conscious of, especially if you work in A&E, because they may arrive in your A&E department before they get here. Vascular things to think about, so little red flags you may see with these. So on the right, I've put more red ones, so your headache, your neck pain, dizziness and vertigo, nausea and vomiting, speech abnormalities and visual abnormalities, which may link to stroke symptoms. Other little things to think about is sensory and gait disturbance, so Horner syndrome, Wallenberg syndrome, which basically is deficits to the cranial nerves, which are 5, 9, 10 and 11. Hematomas, pain, monitoring their OBS, so their early warning score, their modified or news early warning score, and just any bruising or anything around the area. Usually these ones, they do get picked up luckily, but some unfortunately do slip through the net. The other things just to be mindful of are your neurological signs and symptoms. So on the left, so your pain, your upper motor neuron signs, your altered sensation, so you can tell if there's any spinal involvement, so upper limb and lower limb, so is there reduced muscle strength in either upper limb or lower limb, any changes in sensation, so is that numbness, pins and needles, etc. Signs of shock, bladder and bowel, reduced balance, proprioception, and then if you're looking at the red flag side of it, so speech and swallow difficulties, headaches, again dizziness and vertigo, visual disturbances, trigeminuralgia. You can also be looking at, is there anything around concussion as well that might be happening, or irritability, which can also give you some thinking about head injuries alongside the C-spine fractures. Any resp involvement, so if they're going off from a respiratory point of view, you're thinking around C2, C3. So C3 innervates the phrenic nerve, which is responsible for your diaphragm. So just thinking you're a bit more advanced level, is there anything you need to be keeping an eye on? So how are their SATs, how's the respirate, things like that. Moving on to thoracolumbar fractures. So the 4 I've put on the screen, so you've got a compression fracture, a burst fracture, flexion extension, and a fracture dislocation. And I'm going to just kind of talk through them a little bit and see how people find them. So a compression fracture first, which you can see up here. So this is a wedge shape. It's a cortical breakup in the anterior wall. You usually find it'll just break off, as you can see, just around here, and sometimes comes down a little bit. But all of this bit will always remain intact. Really infrequent, as I said, will be if that piece comes off at all. That is one of the big things that distinguishes it from the next type of fracture we're going to look at. This is usually, if I'm honest, about 90% of the cases of spinal fractures that will come in. It's a little bit of pressure, squashes down. What you tend to get is everything's intact, neurologically they're intact, and we'd usually just get them up, see what they're like. The consultants, 90% of the consultants wouldn't bother putting people in a brace, if I'm honest. They find it just makes patients more anxious. So we try and get these people up, good pain relief on board, try and get a standing x-ray and see what it looks like. The only other thing you'd be monitoring for anything like that is if you get a really big loss of height in the vertebral body itself. But otherwise it should be okay. So you can just see a little chip here, really hard to actually detect on x-rays if I'm honest, unless it's quite obvious. The next one, which is the burst fracture. This one kind of similar, okay, but you get just more of a crack in the vertebrae itself and squashes a bit more. One of our consultants here is really good at explaining these, and he actually uses a tin of beans and can't say it, analogy. He uses a tin of beans. If you look at it itself, it's got squash both ways, so it is just direct force down through the spine and squashes it, and it cracks on both sides. So you'll usually you can see quite a bit of it will crack in 2 or 3 places. It's really good on a CT or MRI to look through as well, and you'll be able to spot all the little cracks along it. As you can see, the percentages of roughly there, your standards, what tends to happen with patients, and it just bulges a little bit. These are quite painful for people. It's just a bit more severe than your standard compression fracture. This one tends to, if I'm honest, avoid surgery a lot of the time as well. There's a lot of research out there showing with 20 patients, if you take 10 and operate and 10 that you don't, their outcomes are roughly the same after 1 to 3 years. Most of them get back to completely normal life, manage it really well with pain relief, and the sooner you get them up, the better they tend to be. If you operate on them, you're probably going to get the same outcomes, and you're just delaying getting them up. You're going to give them more pain alongside muscle pain, because to operate on this vertebrae, you're going to have to go in through the spinal muscles and cut some of them out of the way, and then you've got a whole wound that needs to heal. And I suppose if they're stable and the fracture isn't giving them any neurology, then you really don't need to operate, because you're just opening up a can of worms really with the risk of infection to the wound and the wound healing, etc. So these ones, they'd usually MRI just in case, but they tend to be managed conservatively, and they're okay. Just to see that here, so this tends to be how you'd pick it up on an MRI scan, to be honest. Compared to the rest of the spine, it just looks really squashed, and you can just see it's a lot smaller in size compared to the rest of the spine. So you can also see, like I was saying, if you look at it through CT, you're able to spot all the little breaks through the middle of it. So it's quite handy to get, if you're not used to looking at images yourself, get one of the doctors to sit with you and kind of go through the scans, and you can pick out lots of little bits that the more you kind of get repetition with that, you're able to spot it yourself. So a translational or a rotational fracture. So it's anterior or lateral displacement of the spine. You sometimes get the facet joint disruption, or it can be dislocated. As these are quite low down, you normally will see, you'll hear a lot of people getting transverse process fractures alongside them. The transverse process fractures are never really an issue themselves. It's this fracture itself that could be problematic. And a lot of them come alongside rib fractures just because of if you think of the body itself, the ribs are pretty much anchored on around that region as well. With it saying PLC here, it's nearly always involved, so the posterior ligament complex of the spine is nearly always damaged. So the fracture on this scoring system, which I'll talk about in a second, would score 3, and so would the ligament. So usually that would mean this type of fracture would be operated on. It's a difficult one. Usually, looking at it, you probably have a lot of neurology involvement in this as well, and it looks pretty much like that vertebrae and the rest of the spine are separating, and they just come apart a little bit. These ones are quite common for a spinal cord injury as well. Depending on how quick they get operated on, they recover quite well, as long as it's not a complete tear of the cord, which usually, luckily, it isn't. A distraction fracture. Also a big one for spinal cord injuries. It's more severe than a wedge compression one. It's the back part tends to come off, and the spine just twists a little bit. A chance type fracture is basically what they call a seatbelt fracture nowadays, and it's the kind of whiplash effect on your lower spine, and everything just pulls apart, as you can see, and just lifts a little bit. The disc in between gets damaged, and usually one part will just come off. The ligament itself is really high risk, and the spinal cord can often tend to be pulled apart as well. These ones usually need surgical fixation as well. it's basically all the other fractures we've mentioned into one. And it can basically be sustained from a side-to-side issue or a front and back like that. Looking at it on scans, I know it's quite difficult to see, but here you can always see that the front has been completely squashed down and you've got a big twist going on in the back. And where else? We've got one here as well, pretty much same kind of one, so it's really come down on the front and clamp down on it, and it'll tend, what can happen quite often is because of this, it'll push down and the vertebra itself will shift out the back, and that's really something you don't want happening, is because this bone itself then is right on to go straight into the spinal cord. And you can, with quite high velocity traumas, so falls from a height or jumps from a height or some really high speed RTCs, you will actually see some of the pieces of bone have got stuck in the spinal cord that they'll have to remove in surgery. So spinal fracture classification, just briefly, so there's 3 different ways to grade these. So the AO and the Denise, like we already mentioned, and then they tend to be not really good for picking up who needs surgery or how you clinically manage them. So it can tell you obviously whether something's stable or unstable, or it gives you a score on the AO series. But for a long time, the surgeons felt that wasn't really enough to kind of guide your clinical management. So in 2005, there was a new classification system that came out called the TLIX, which we can briefly chat about. And really what the TLIX is there for is to guide clinical management. So it recommends, depending on the score, whether you can manage conservatively. If you get a certain score, it's kind of a discussion between patient and consultant, and then if you're over a certain score, you should be surgically managed. So briefly, so in 2005, as I said, the TLIX came out. So you've got your Denise, as we've seen before, which is your 3-column theory. You've got your AO, which is a series of letters and numbers depending on the type of injury. And then you've got the TLIX, which is designed to basically include the neurological status so that you can be guided on the clinical management. So it's got 3 parts, 3 different scoring systems, which is morphology, the ligament integrity or stability/instability, and the neurological status of the patient. And if we quickly look at it, so Denise, as a reminder, as we've seen, I've just put a little link there so people can read a bit more, and you'll find all the classification systems on that one, to be honest. The AO, as we've said, so this one differs from the TLIX itself that I'm going to speak about, because it doesn't actually determine the treatment you're going to have. It only gives you 3 classes of those type of fractures, and there's 3 different components to each one, so it gets quite confusing and it's really long-winded in my opinion. They look at similar stuff, but just don't, so this is also the AO, it doesn't look into depth. The TLIX itself obviously recommends different treatment types. So what it looks at, you score each section 0 to 4, okay? So injury morphology, the integrity of the ligament, and the neurological status. There's a maximum of 10 points, and if there's actual numerous spinal fractures, you have to grade each of them singly. So one region might get a 7, and then you don't add them all up, it just goes one on each one. So this is how you do it. So if it's each one, if it's a compression, they get a point. If it's a burst, they get 2 points, and so on. And then same with the ligament. If it's intact, it's 0. If it's suspected, it's 2. And if it's injured, it's 3. And neurological, as you can see the scores as well. And the one thing people usually ask is how come a complete spinal cord tear only counts as 2 points and an incomplete counts as 3? Same with cauda equina. So with these last 2, the reason that would be really recommending surgery would be the fact that an incomplete cord, if you can fix it quicker, has a better chance of recovery and not being paralyzed for the rest of life, essentially. If they're a complete cord injury, the chances are it's very, 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 very limited that you ever hear of recovery of people with that type of injury. Whereas if it's an incomplete and you fix it and they get rehab really, really well, you can see a lot of people walking again. A complete tend to end up being wheelchair bound, unfortunately. So it's the fine margins of, if you're trying to decide if they're an incomplete, you should be scoring higher so that you really push the chance of having surgery. Same with cauda equina. It's obviously really time critical if they do have a cauda equina, and they should be operated on so that you're reducing the risks of really altering their quality of life if they end up with long-term bladder and bowel issues. So the way they score them, the fractures we've already looked at, just tells you the points they get for each one, and why they get them. So the PLC, which I keep talking about, so the posterior ligamentous complex, is basically these group of ligaments, and they, if you have any injuries to any of these areas or to the facet joint capsule, that determines you have damage to that complex, and you will score a 3 automatically for that. So 0 to 3 is you don't need surgery. A 4 is a discussion between the consultant and the patient, and anything above a 4 you'll be having surgery. So as you can read above, a torn PLC doesn't really heal, and realistically you're gonna have surgery if you've got a PLC injury, because you won't have that injury on its own without a fracture, so that'll put you over the threshold of 4 to have an operation. Neurological status, which they'll also look at, which you can see is, are they intact, is there a nerve root issue, and we've kind of touched on this already, saying why they might have that surgery. So it kind of speaks for itself, really. As I said, one of the key points is an incomplete cord, usually benefits from surgery than a complete. It's strange though, so a lot will kind of differ consultant opinion on a nerve root issue versus a complete cord. Obviously such different injuries, but to be honest, a lot of them, if it's in orthopedic spines, even if it's a complete cord, they'll fuse it anyways to prevent any other damage in the long term. Most will still operate. So conservative versus surgical. There's a lot of controversy, I suppose, over this. Usually it depends on the consultant. Most will fix, as I said, if the ligamentous complex is involved, or if all 3 columns are involved, they'll always will as well, because they won't want to risk the patient getting a spinal cord injury. Any neurological deficits, they'll always operate as well, and that's an emergency. There's insufficient evidence, as I said previously, that if it's one that's kind of on the fence and you could manage them either way, but they don't have any neurological issue, the need to rush a surgery isn't that big. They'll tend to try and manage them conservatively. If they fail at that, then they'll operate. Otherwise, they'll try and just say, have a go with physio. If a patient really, really wants surgery, psychologically they don't really engage very well anyways, and you have to go back to the surgeon and say, you know what, they're not managing it, you might need to have a think. But we usually will do a standing x-ray, see what they're like, and see how they go. Other issues, if you fuse a spine, there's research after a year, 3 years, 5 years, and so on, that looks at the level above or below that region that you've fused and put metalwork in will also need surgery. So once you start putting metal into the spine, or putting any sort of fusion or screws, bolts, anything like that in there, you're probably going to have to go back in within a few years and do another surgery, and probably give them a bigger operation again and put more metalware in. That obviously you're going back in through a wound that's previously healed, so the risk of that not healing again is poor. The chance of infection is higher. The chance of it actually not fusing to the old metalware and causing more problems is also massive. Some people find that the metalware is painful and want to come back and have it taken out. So they try nowadays to limit the people they need to do this with, and it's only if you're really starting to get instability that they will look towards surgery. Some younger people who've had it because of RTCs and stuff, if the screws come quite close to the skin because their posture, they come back purely, to be honest, for cosmetic reasons, because if they're young and they're going on holidays or anything like that, they don't they're quite body conscious, thinking that people can see it. It's usually not the way, and it's very infrequent that you can, but it's difficult if they're in that position. Conservative management, as I've spoke about, so if the consultant's not really sure, they tend to say to ourselves, let's get them up with Patrick or whoever the physio is on the day. We'll send them for a standing x-ray, and I'll come back to you in 48 hours, and if they're doing really well, I'll leave them with you and they'll just crack on with physio. If they're doing really crap, give me a ring and I'll put them on the list for Friday. Physio and standing x-ray if able, as I said. As the above, what we do for the initial x-ray, we tend, if we've got some off-the-shelf braces, we put them in, make sure everything's okay. They usually have a neurological assessment first, make sure everything's okay, and you can check that after just to make sure nothing's changed. If it has, get in instant touch with the surgeon, let them know. The big thing I've noticed with certain things, you can have off-the-shelf braces, but you need to make sure it covers the level of fracture. So if it's, like I said, if it's an L1 or something like that, you need to make sure they're in a TLSO, not just an LSO, or if it's lower, something like that. So just make sure that the brace is for the right type of fracture. Normally, a brace itself, if they're putting people into them, tends to be as comfort allows. There's lots of evidence out there now that says braces aren't really the best management going forward. They just increase anxiety, and patients become really reliant on them. And all a brace is really for a patient is a prompt to not do the positions that a consultant doesn't want them to do that might damage the fracture or damage the fixation they've had. So as I've said, braces, there's really recent research out there saying they don't work, or some patients like them, some don't. But I've seen cases where we put people in them who are already really anxious, and you might hear from someone who's checked in on them in clinic a year later and they're still wearing a brace that they really don't need. Their spine will have fused together or healed by now, and they've just become really overly reliant on that, and it's limiting their quality of life because they're not doing so many movements and things they should now be allowed to do, and they just become fixated on wearing this brace that they're long past using. So if we can just get them up normally, the things we wouldn't want them doing with the spinal fracture or with the spinal fusion would be any over flexion or prolonged flexion, which is stuff like, so tying your laces and things like that are fine because you're bending over and you're only there for a few seconds. It's things like where they're in a position for a long period of time. So example being hoovering, where they're slouched over holding the hoover for 5-10 minutes at a time. That's encouraging the fracture or the metalware itself to really bend and stay in that position for long periods where it might start pulling away a little bit. Over rotation, so where they're really twisting and over twisting for things they don't like them doing either. And the other thing is any heavy lifting. A spinal surgeon's heavy lifting is usually half a kettle to a full kettle of water. So all those three things they don't like them doing for the first 3 months. Physio itself, so what we normally do, just like any physiotherapist would do, is check their limb power. So if it's a C-spine fracture, their upper and lower limbs. If it's a thoracolumbar one, checking lower limbs, sensation. If there's any sort of spinal cord involvement, they need an ASIA before they get up. Teach them the modified log roll, which is essentially bending your knees, rolling onto your side, dropping your legs over the edge of the bed and anchoring yourself up with your elbow. Standard mobilization, just see how you can get them up. I'd always start with handheld assistance of 2 and go from there because you can kind of judge how much they're pushing or pulling. If they need a Zimmer, great, but just think if it's your old people who are really bent over, I tend to try and avoid Zimmer frames if I can, because you don't want them over flexing and bending over onto Zimmer lots because you're doing exactly what the consultant doesn't really want them to do. So think about things that you can get them more upright. So I've sometimes actually got a Zimmer frame and put it really, really tall, which feels alien for them, but it's actually got them into good extension and they're a lot better. Here with outpatient physio, for any of these type of ones, in agreement with the consultants, we don't refer them for standard physio unless it's something like a foot drop post-op. No spinal exercises for at least 3 months, and all we really advise them on is just build up your walking tolerance, and as a rule of thumb I say every day, like walk the equivalent of an extra lamppost when you're outside. We don't really want anything upsetting the process of the fracture healing, or if it's spinal fusion, anything's going to upset the metalware, so we don't refer for that. And if someone's going home with the likes of a discharge to assess or a hospital at home, it's making sure the therapy staff that are going to review them in their own home are really aware of the things they shouldn't be doing, because you don't want someone coming back in where they've had an issue because they've been advised on doing something that's not really advised for that type of injury. As I said, they can be referred if there's any other issues, and if not, you can kind of touch base with us here and we can kind of advise on that. And that is all. Thank you very much.